So I'm Kam Bhui, editor of the British Journal of Psychiatry, and one of my first duties and great privileges is to interview the presidential candidates for the Royal College of Psychiatrists. I'm joined by Honour Scarlett, who's a sixth form student, and together we're going to interview the presidential candidates, the first of whom is Professor Sir Simon Wesley from King's College and South London and Maudsley Trust. Simon, why do you want to be president of the Royal College of Psychiatrists?
That's a good question, isn't it? But I've been a psychiatrist for 30 years, and I have to be honest, I've loved every moment of it. I think it's a wonderful career, and it's been very enjoyable, challenging, and rewarding. And basically, psychiatry has been very good to me. And I do, at the risk of sounding slightly pretentious, but I do think I'm at the stage of my career I want to give something back to the profession.
What is the single most important issue that you will address in your presidency?
There's a lot, aren't there? There isn't just one. The thing that most concerns me about the future is the issue around recruitment. And also because so much else stems from that. And to get recruitment right, we're going to have to address what a whole host of other issues, like our relationship with our medical colleagues, our relationship with our other colleagues in the multidisciplinary team, our relationship with the public, the fallout from Francis, Greenway, and the debates on specialisation. All of these things, I think, are actually recruitment issues for psychiatry. And everything for me comes down to that issue. If we don't get good graduates coming into psychiatry, keen and enthusiastic for the next generation, we're in big trouble. And if we get that right, I think most things will probably sort themselves out.
All right. You started talking about recruitment, so I think I'll ask Honour to ask you a few questions earlier than we planned. Honour, do you want to ask your questions?
Sure. What will you do to improve recruitment into psychiatry?
Well, I mean, it's a big issue, that. I mean, the first thing I want to remember is psychiatry has never been the most popular of medical specialities. If you go into psychiatry, as you're thinking of doing, you won't become rich, you won't get the kind of plaudits that our friends in surgery and cardiology get and things like that. There are issues around psychiatry that you've got to accept. You know, people don't always understand this. There's a lot of stigma attached to our patients and things like that. Some of our colleagues will diss us and say, oh, it's not scientific, which is rubbish, by the way, but that's what they say. All of those things are things that, you know, you get used to in psychiatry. But what's happened recently, though, is rather more worrying. I mean, I can talk to you about our medical students. Okay, I'm in charge of our medical students at King's, and what they say. And many of them come very, very keen and interested in a rather vague way. You know, they're not quite sure what they want to do. They know they want to be doctors, and then they start to think about psychiatry, because psychiatry is very much for grown-ups, by the way. It's a grown-ups discipline. Kids do surgery, adults do psychiatry. But they have a look at us, and they're a bit confused by what they see. You know, they're not quite sure what it is that a psychiatrist does. They're not quite sure what is the skills that we have. And they're not, sometimes they come back and say, I wasn't even sure who the psychiatrist was. So that's something that we've got to change about our image, to make it absolutely clear. I mean, when we were chatting beforehand, you said you'd like to miss medical school and go straight into psychiatry. No, you wouldn't. Definitely not. I'm hoping that you first and foremost want to be a doctor, and that's really important and absolutely fundamental to what we are. And then, as you gradually understand more about medicine and you realise where the excitement is and where the challenge are, you want to go into psychiatry. So that's what we've got to do. We've got to reinforce our medical identity. We've got to show what it is that we do well and give good role models for the next generation of budding psychiatrists like yourself.
Okay, thanks. Students with mental health problems are dropping out more than ever, and within 4 years the number of student suicides has doubled in women and increased by a third in men. Do you think universities are doing enough to support students with mental health problems, and how would you prevent this incline in student suicides / dropouts?
I wasn't aware that the numbers have actually gone up in students. That's true, is it? I actually wasn't aware of that. There's two things there. Firstly, there's both formal and informal things going on here. So the formal answer to what you're asking is, we have student healthcare clinics, and actually they're pretty good. They're often staffed very well with counsellors, psychotherapists, etc. And students who are in difficulties can go to them and they can get help. And that's good. But that's only half of the issue. Almost more important than that is the informal support that students get from each other. And what you find is that where we've had students in difficulties, the first people who spot it are their friends. from their own social circle who say something's really not right, something's going wrong here. And then they can come together and they can encourage that person to get support. So we should, of course, invest in student healthcare, student psychotherapy schemes, things like that, which are good. But equally, it's a responsibility on everybody in the university to help each other, to support each other, and encourage people who are having difficulties and are too shy or embarrassed or feel stigmatized to mention it, to come forward and get help when they need it. So it's not just the job for psychiatrists and doctors and psychologists. It's really part of the fabric of every good university that it's a supportive environment.
Okay, thanks. And what can you say to attract young people in schools to consider psychiatry a profession?
Well, I go back a little bit to what I was saying before. I mean, I do these talks for sixth forms, and I don't start by talking about psychiatry. I talk about medicine. And it's interesting to say to students who are thinking of medicine or in Handel, what might attract you to a career in medicine? And one gets very similar answers. First of all, they usually talk about they want to care for people. They're really into, caring profession. They want to help people. Then they usually talk about the science. So some of them mean, they've been reading The New Scientist, or they're doing very well in their biology and chemistry, and they want some good science, and that's good. And then there's always some who have almost wider ambitions about changing society, and they'll know about, social determinants of health or global health and issues like that. So I get people to talk about that. And then from all of those, we can start to say, well, now, let's think about what I do for a living. I'm a psychiatrist. So psychiatry is about science. So it's, our organ is the brain. We're interested in the brain. And neuroscience is very important to us. But by the way, we're not neurologists. And then we talk about caring for people in the wider, kind of the personal agenda, about psychology, the mind, and interactions with people. Well, we do a lot of that, but we're not psychologists. And then I talk about the wider social influences on health, and also the kind of social dilemmas that psychiatry throws up. I mean, it's, we're the only profession that can actually detain people. We often are involved in very complicated ethical issues. We're often involved in issues, what's the difference between a normal emotion, sadness and depression? Where does normality become abnormality? And we're starting now to talk about, the social world that we live in, sociology, anthropology, issues like that, and we do that. So now, hopefully, I've convinced you and anyone else that psychiatry is about brain, mind and society, and it's the only branch of medicine that does all three, and that's why it's so interesting. But I don't start by just talking about psychiatry. Talk about medicine first, and then expand it to see what is it that we do that's special.
Thanks.
Simon, where has UK mental health policy gone wrong, given we have more detentions than ever before, poor emergency mental health care, threats to local services, so reducing coverage, and there is the issue of low morale in the profession?
Your predecessor, Professor Tyra, a beloved memory, I'm just going to quote what he wrote about this just last month, because I think I'm actually going to read it because it's really well worth listening to. He talked about what's gone wrong, and this is what he said. He said autonomy for the practitioners has almost entirely disappeared, to be replaced by a rigid system of care in which patients encounter a bewildering number of professionals carrying out specific regimented tasks but rarely developing meaningful relationships. I thought it was very good, actually, because it does talk about what has gone wrong in care, and it talks about, he's talking first of all about the imposition of kind of bureaucratic restrictions on what we do. He's talking also about, the obsession, for example, with beds. I've just come from this morning, where I was nearly late, because we had our regular clinical meeting, the management clinical meeting. What did we talk about? We talked about beds, as usual. We talked about the fact of overspill. We have 50 overspill beds, and why this is terrible. We're all completely obsessed by beds, as if that's the sole reason for existence, is to prevent admissions and reduce beds, because it isn't. It's about delivering care. We talked about money. This new thing that got called, what was it called, zero budgeting. Have you heard of zero budgeting? No, nor had I. Anyway, it isn't zero budgeting, it's minus budgeting. It's yet another word for cuts. So, yet again, we're being trapped by these financial burdens that are put upon us. And we talked remarkably little about patient care and quality. And that's what's happening across all services, wherever they are. They're facing these dilemmas. So I think then what's gone wrong? I mean, to talk to my wife, who's a very noisy GP, genuinely she is actually, she's a senior GP, and she'll tell you what's gone wrong is that, her patients now don't know who their psychiatrist is. They're moved through all these disconnected services. There isn't a single patient pathway, a single patient journey. There isn't a sense of integration, and there isn't a sense of continuity of care. So I think we've got these fundamental structural problems. We've been forced into bureaucratic solutions to clinical issues. We've lost continuity of care, which is good. We've probably over-specialised, and we've probably lost some of the ethos that drives psychiatry and makes it so worthwhile. So I think, there's a lot that's gone wrong.
Is there a role for doctors as managers, or just good managers working alongside highly competent senior clinicians?
I'm pretty ambivalent on this one, actually. I've known some doctors who have been managers, some have been very good, and some have been absolutely dreadful, to be honest with you. I don't think there's anything specific that says doctors naturally make good managers. I think what makes good managers are the ones who are interested and able to work with clinicians, whether they're clinicians or not. They have to be able to work with clinicians, and they have to also, I think, the ones I've met who've been very good, and I've been very lucky actually, I've had some very good managers, is they also make the clinician feel listened to, and that the clinician is part, of the system of care, that they don't marginalise or isolate clinicians. So they're very clinically informed, and they make the clinician feel engaged. I'm neutral as to whether they need to be doctors or not, to be absolutely honest with you. I think some of the best ones I've met haven't been.
Okay. What do you think about the role of the public in managing the medical profession's roles and responsibilities? You've alluded to that a little.
The role of the public in that. Are you talking here about the increasing use of laity, for example, in bodies like CQC and GMC and all the other
society wanting to hold
yes.
doctors account?
Well, first of all, that's a social change that's happening, and we have to respond to that social change. And fundamentally, there's nothing much wrong with that. But where it, I think, starts to cause problems is where that impacts on what we do, which is the absolute virtue of professionalism. And that came out of Francis, it comes out of Greenway. If we ever lose the sense of ourselves as a profession, then we are in trouble, and that is the worst thing that can happen to the public. And I have seen examples where that does happen, where people almost denigrate the idea of what a profession is and what a profession does. That I hope doesn't happen, and so long as that doesn't happen, no problem with increasing use of laity or whatever you wish to call it, the public. I think, having said that, let me qualify that as one thing. I don't like sometimes the element of tokenism that comes in, and that because there isn't such a thing as a public, and I've been on committees where there's been one person who seems to speak for the public, and I just think that's a bit nonsensical. How can one person speak for the public? So I think if we're going to get more public engagement, it has to be a genuine engagement with a genuine representational element to it, and sometimes that doesn't happen.
There are many subspecialities in psychiatry. Again, you've already alluded to this. Do we need so many, and can we afford it?
Well, what's happening across medicine is a realisation that in certain disciplines, and it's not us, by the way, it's in medicine and surgery, specialism has gone too far, and that we've lost the general physician and the general surgeon. Now, psychiatry actually hasn't lost that tradition, and our most active area is, of course, general adult psychiatry. And having just come back from the conference in Manchester, it's a very lively, active and flourishing discipline. And so we are not really the targets of the criticism that's been put across the rest of medicine. But having said that, I think we should be aware of creating more specialities than we have. It sometimes gives the impression of a house divided, which isn't good. And I think we should welcome the other initiatives in the shape of training review, the emphasis on long-term conditions, on continuity of care, on apprenticeship as a method of teaching. All of these are good for us and should be welcomed. Very rare that you say that after a government report, that we welcome it, but this time, when it's good, it's good. And the system of credentialing, which is allowing people to develop specialisation further into their career than has been the case before, giving much greater flexibility and the ability to move between different specialities, as I myself have done, I think is a good one. We'll have to see how it works, have to make sure it doesn't create two tiers of consultants, which is one concern. But I think for once, we should say that's good. And we should also give praise for another thing that's going on with one of my bête noires has been the destructive impact of modernising medical careers. 6 or 7 years ago, or mangling medical careers as it was better called, which prevented people from doing what psychiatry has often done, which is we take people later on in their career. I don't know about you, Kam, but I did general medicine for a couple of years, not because I wanted to do general medicine for good, but I just wanted to have a broader based experience and then go to psychiatry. And that became impossible under MMC. And there's now a clear signal that that was wrong, and they're backtracking and going back to this broad-based curriculum. So you can have a much broader exposure to specialities, either because you haven't quite decided what you want to be. You know don't want to be a surgeon, but you're not sure whether you want to be a GP or a psychiatrist, paediatrician, physician, or because you have decided that you want to be, get more exposure to other specialities to make you into a better doctor and a better psychiatrist. That is really to be welcomed. That is absolutely excellent, and that in itself, I think, will greatly help our overwhelming problem of recruitment.
Academic psychiatry is producing little in terms of future leaders and innovative research for improving patients' lives. Do you agree? And if so, what is your remedy?
That's a cheeky question, Kam, isn't it? No, of course I don't agree with that. Academic psychiatry has done a lot in the last 30 years. I mean, look at some of the things that myself and my colleagues have done in chronic fatigue syndrome, including one of your colleagues, where we're filming today in Barts, Peter White, have really changed the care of a group of patients who used to have terrible care, and now we've really, I think, made it far better. So I'm absolutely unapologetic about the important role that academic psychiatry plays across the whole piece. What you are getting at, I think, is, for the last 20 or 30 years, there hasn't been a revolutionary change in psychiatric care and treatment. We haven't had our insulin moment or our penicillin moment. To be honest, nor many other specialities, these things come highly unpredictably. Like many of the things that really change things in medicine or in society arise completely de novo. Who predicted HIV or who predicted the internet? Nobody. So I don't know where there will be a fundamental change in the treatment, say, of Alzheimer's or schizophrenia. I'm optimistic there will be. I am. And I think what we should do for that is, chance favours a prepared mind, and we'll see where it comes from. Neuroscience, genetics, a combination of all of them, I don't know. But what I do know is for us to be able to seize that moment, we have to ensure that all of us, and this is not just about academic psychiatry at all, this is about the whole of psychiatry, we continue to be imaginative, inquiring, inquisitive, sceptical, questioning, etc. So when that moment comes, we're able to seize it. So I'm not pessimistic about the future, but equally, you remember the great Tony Blair was interviewed by Paxman, and he said, well, I don't make predictions, Jeremy. I never have, and I never will. You have to think about it for a moment. I think it's quite funny. Anyway, so I'm not going to make predictions.
Okay. Finally, what will the legacy of your presidency be? That is, what will you leave as a challenge for the president after you?
Well, I hope I don't leave anything behind for them to apologise for. I think we do far too much apologising in psychiatry, to be honest. I think I'm almost going off on a tangent immediately, but I think we have to be really much stronger talking up psychiatry and what we do. So I hope I don't leave anything to apologise for, but I think if there is a legacy, so long as we have a psychiatry that is confident and articulate and happy with itself, then I think the future is going to be pretty bright, and that's what I hope to be able to contribute in some way or other, because that's the best way. A good, confident psychiatry is the best way of improving the care of mental illness and the way that we treat people with mental disorders. And if I really didn't believe that very passionately, I wouldn't be here doing this interview.
Simon, thank you very much, and good luck with the election.
Thank you. Okay.